me and Dr. Ford-Pa. So we will be presenting on clinical considerations of parent refusal of interpretation services. And Joy, if you want to start off with intros or anything.
Well, I will just I will follow you to welcome everyone, and I don't have to introduce you, Kendall, because you just did. But so as you will hear, Kendall is she's a joint degree student, MPH and MSW, and I had the privilege of working with her on the MPH part of her field work. It's very exciting work, and one of her deliverables that was required for our program was going to be a case presentation, which due to COVID, since it's upended everything in the world, of course it upended that. And we felt like we really wanted to give Kendall an opportunity to share this great work with the SPH community, as well as the Jane Addams community and the Lurie Children's community. I think we have representatives from all those entities here. So want to thank you, and also thank Dr. Rebecca Ford-Paz, a colleague of Kendall's, who will be responding and giving us some thoughts on what Kendall has presented. So we'll have everyone muted, and then Kendall will speak. She'll introduce Dr. Ford-Paz. We'll have little time for question and answer, and then you'll be able to unmute yourselves for any questions. So thank you again all for coming, and Kendall, you can take it away.
Thanks. Great. So hidden in plain sight, clinical considerations of parent refusal of interpretation services. Let me make this smaller. In acute settings. So thank you for taking your time to participate in this presentation. This comes from a case presentation I initially prepared for my applied practice experience at Lurie's, as Joy just said. And it's focusing on those with parents who can be considered limited English proficient, and working with those families. Oh, the whole PowerPoint is showing. Thank you. Oh, let me fix it really quickly. It's an advanced. There you go. Perfect. So working with I was working a lot with parents that can be considered limited English proficient, and this provided me a better opportunity to better utilize my clinical work with also what I've been learning in both my social work and public health courses. And as previously mentioned, we're really fortunate here to have Dr. Ford-Pa here today. She's a child psychologist and advocate for Latinx and immigrant refugee populations, and she'll be presenting further on the use of interpretation services in mental health settings with those who have experienced trauma or are in acute settings. So first, I'd like to provide a brief introduction on myself. As many of you know, I'm completing my master's in public health and health policy and administration. And then I'm also completing my master's in social work, focusing on mental health. I recently had an internship at a refugee resettlement agency, Refugee One, if any of you are familiar with it. And there, my placement was in their medical case management department. So when I was working in that position, I really got to learn the importance of having access to interpretation services and a lot of the nuances that come with developing a language. And even though you might be able to be conversationally fluent, being able to truly comprehend everything that's going on in a health setting can be a really challenging experience. Even if you are fluent in English, there's still a lot of words that are used in medical settings that aren't just commonly used outside. And then also I've had a multicultural upbringing. I'm multicultural myself. I always grew up around people that spoke different languages, which is partially why I've been able to pick up words here and there in a bunch of different languages, because it's just always been really normal to me. So for this case, for this presentation, I'd like to be focusing on Celeste. She's a 14-year-old Mexican-American girl, and she is primarily English speaking. She has a history of sexual trauma and suicidal gestures, and she came to the IPU after experiencing some symptoms associated with anxiety and depression. So, low mood, there's an increase in aggression, compulsive behaviors, and she ended up being admitted to the IPU, the inpatient psych unit, for suicidal ideation. So for the inpatient course, Her length was about 5 days. It was a Friday to Monday admission. We had 2 individual sessions, and she participated in 1 family session. So as we can see, I really didn't have as much interaction with her during this admission, and that's not really atypical for patients that are coming in for suicidal ideation, that they would then step down to another form of treatment that they can go home to, maybe a partial program or an intensive outpatient program where they would work more closely with a clinician. So in total, I had 2 sessions with Mom, one on Friday and then again on Monday. I was her primary clinician and was supported by the Child and Adolescent Psych Fellow and our supervisors. The length of the stay, as I said, is really not uncommon. And for the purposes of this presentation, I'd really like to focus on these family sessions with Mom. Dad was unable to be present just due to his work schedule. However, we were able to communicate at times via phone. So for my initial session, these are the goals that I typically have, and they all contribute to my overall assessment of both Celeste and her family. So really just getting a good idea of what the last few years looked like for Celeste, how do they perceive her as a person, what are the patient and family stressors in general, and of course, safety planning. So during that first session with Mom, it was going all right, but there were just something seemed off. I noticed some clues indicating that she might have some challenges really understanding what I was saying. And these clues included inconsistency in timelines. I found myself also having to reiterate and rephrase questions. A lot of her responses didn't really seem like typical responses for these questions based off my experience. And also she was making a few nonverbal cues indicating confusion, such as furrowed brows, loose eye contact. There were a few moments where I saw her breaking eye contact and kind of looking away as if she were thinking. And this is also a facial expression that I even make myself when you're translating something in your head. So what I did in the session, given those clues, is I asked Mom if she would have felt better to speak in Spanish, and I informed her in both English and Spanish. I was able to inform her that we had interpretation services. She appeared interested, but continued to decline, which I respected. So in this case, I was able to identify that Mom would potentially fall under being limited English proficient. And limited English proficiency, or LEP, refers to those who don't speak English as their primary language and have limited abilities in English. This tends to really show itself when you're in these medical settings, as I said. So there are 3 perspectives you can use to think about this issue. First, there's a legal one. We can ask, what are the patient's rights and what is our role as a health provider? Next, there's an ethical perspective where we can consider, are they able to consent without access to an interpreter? And lastly, there's the World Health Organization's social determinants of health. With this, we can identify ways in which the family may have been left vulnerable. So some relevant laws include Title VI of the Civil Rights Act of 1964, which prohibits discrimination based on national origin. And this means that hospitals receiving federal dollars are also required to provide interpretation services, and it must be documented if a patient does choose to refuse services. In the case of this family, I don't recall seeing any notes about her choosing to refuse services. But I did write that for mine. And I think a lot of it is when you are working with these limited English proficient patients, that it's really hard to become aware of this unless you're really in an enclosed space with them by yourself sometimes. And then under Executive Order 13166, it focuses on access to interpretation services within federal agencies. So again, relating back to where we're getting federal funding from. And then state law is the Language Assistance Services Act. And this law was signed in 2004 and makes it so that arrangements shall be made for interpreters or bilingual staff to ensure adequate and speedy communications between both the patient and the staff member. I think one thing to note though with this law is that it states that they shall versus they must, and this provides some leniency whether or not the healthcare provider has to provide this service, even though it would be the most beneficial for the patient. And then ethical principles. The ethical perspective here is taken from the National Association of Social Workers, highlighted our notes on the patient's right to self-determination, in this case meaning mom has the right to refuse these interpretation services. And then there's also notes on seeking to enhance our patient's capacity to change and address their own needs. So with this one, I really battled between mom does have the right to refuse services, but on the other end, as a social worker, I seek to enhance her ability and capacity to change and address the needs in her own life. And as we noted with Celeste, she's had a lot of things happen to her, and given her presentation, she was really sick. So really that battle between, I know there's only so much I could actually do with Celeste at this moment. I could work mostly with mom, but without having access to an interpreter, there's a wall between our ability to communicate. But she also does have these rights to not utilize that if she doesn't choose to. And lastly, what came to mind were the social determinants of health. So limited English proficiency would fall under intermediary determinant. And one thing that we've seen time and time again is that it's been well established that there's an association between limited English proficiency and poorer health outcomes for patients and the children of families where the parents are limited English proficient. It's really important to ensure that our patient's family have access to interpretation services when needed, due to it both enhancing our ability to communicate and also their ability to consent, which goes back to those ethics. So for the social determinants of health, highlighted here is where limited English proficiency would fall underneath. And displayed is the social determinants of health framework developed by the World Health Organization. So limited English proficiency would be an aspect of the individual's psychosocial factors. This framework can be beneficial when thinking of the root cause of a condition and in identifying where social inequities exist. Through it, we can view health as a social justice phenomenon. To briefly summarize this concept, so structural determinants include public policies, cultural values, and the justice system. They interact with and also include groups people are classified in, like gender, race, and class, which fall within the same category as socioeconomic position, contributing to a social gradient effect. Intermediary determinants are material circumstances, psychosocial factors, behavioral and biological factors, and the health system. As we can see by the positioning of the health system right over here, it's able to mediate many of the effects of other social determinants and also have an impact on individuals' overall health and well-being. So outline are the determinants most relevant to this case. Public policies include those associated with her being a Medicaid beneficiary, immigration policies, and those at DCFS. Cultural values includes those that provided her family a more traditional view of mental illness. The family's socioeconomic position was relevant due to its ability to increase or hinder their access to treatment. And for intermediary determinants, the patient's behaviors and associated biological factors include the symptoms presenting, which were associated with PTSD and OCD. Psychosocial factors include the traumatic events, her family's ability to function as a unit, the impact of these traumas on her family overall, and her parents' ability to speak English. Lastly, that's where we come in yellow as the health system. And as I said previously, we can really mediate the effects of said determinants by aiming for equity instead of equality in the treatment of our patients. So I'd like to bring us back to my final session with the family. It was on a Monday, and I spent the entire weekend thinking about the laws, the ethical principles, social determinants, and thinking of what this session could really look like between mom and I. I had my typical goals for a final session, but enhancing their ability to communicate was a really important one for me. So in this final session, we requested an interpreter be present. We were only able to begin with a tele-interpreter, but that was still a great resource. I did this mostly due to wanting the resource to be available for mom. She decided she wanted to use it, and also my own discomfort, I have to admit, was one of the reasons why we had the interpreter present. She continued to respond in English to me, but she appeared to be listening to the interpreter. An in-person interpreter later came in about 15 to 20 minutes in, and I noticed a huge shift in mom's presentation. She looked a lot more comfortable, and eventually ended up speaking exclusively in Spanish to me. And she was able to disclose substantially more information then than in our prior meetings and conversations. I was also able to have a more clear conversation about what the treatment course might look like, and what their future for Celeste might be looking like. And when the patient joined the session, mom continued to speak in Spanish, and Celeste primarily spoke in English. In their conversation, she stated that she'd never had a conversation like this with her mom. Mom was able to really express herself in a way that it seemed like she hadn't been able to previously. It also allowed for psychoeducation on the patient's on her symptoms to be provided in a language that mom completely understood and that she would be able to better communicate with dad. I was able to provide psychoeducation handouts in Spanish so that dad could be better included, but being provided those handouts and also having someone to verbally explain those things to you in case there's just, you know, something missing or some disconnect is a lot more helpful. So really what happened next? Due to her insurance status, she had 3 options for partial hospitalization programs, which would have been the best fit for her. Of these programs, there was one that I felt would be the best fit for them due to the many needs that they had, really how sick she was presenting, and ultimately a place that I felt provided the amount of resources that they would probably need. She was able to transfer immediately to this program, and they were provided a Spanish-speaking clinician. I think a really big part of what led to them going to this program, which also was going to be more time intensive for the parents, was that because we had the interpreter present, I was able to have a more clear conversation with mom about the different options that they had and why I thought the best fit was the best fit. During their time there with the Spanish-speaking clinician, mom was primarily speaking in Spanish and Celeste was also speaking in English, which I think was interesting. And the clinician found herself having to act as an interpreter for them, but this also allowed them to both express themselves in ways that they felt more comfortable. She also found out a really big piece of information that maybe could have changed things for them had we known. And this is that the family isn't documented. So documentation status is another social determinant that research shows can have a huge impact on help-seeking behaviors and an impact on health overall. Currently, there's limited literature on refusal of interpretation services from a patient perspective, but this could also be an underlying problem among those who've been in the US longer and who are maybe trying to fly under the radar a bit more, who maybe feel less able to advocate for themselves and demand these services out of fear of any of the circumstances they're in. And lastly, I'd like to close off with identifying my own areas of privilege. So one of the social work standards and indicators of cultural competence is self-awareness. I'm an American citizen, I'm a native English speaker, and I was in a position of power. It wasn't really typical for me to ask patients about their documentation status, but in this case, it would have provided clarity and guidance with how to respond to the situation. And another part is that as the clinician on this case, they were really actually my only patient. So I was also better suited to have identified this need than everyone else that they interacted with before they saw me. And I was able to catch this because they were really my sole focus at this time. So we have some discussion questions to guide Dr. Ford-Pa, and they are: why may parents be refusing interpretation services? How can clinicians respond when we find ourselves in these situations? Because it is really, you know, it's uncomfortable and you don't want to insult the parent, but also there's a feeling within that you don't know if you're doing your best work. How can we ensure that families comprehend the benefits of utilizing interpretation services? And lastly, what role does documentation status have on healthcare utilization? So then I will also be doing the slides for Rebecca. Oh, that is not gonna work the same way. Give me one moment, guys, sorry. First time using screen share.
All right, should I get started then, Kimberly?
Yeah.
Okay, good afternoon, everybody. My name is Rebecca Ford-Buss. I'm a clinical child psychologist at Lurie Children's. I'm a member of the Trauma Treatment Service and also a psychologist on the Center for Childhood Resilience team, where we do much more school-based and community-based work and advocacy. In my advocacy roles, I have been involved around my special interest in immigrant and mental health and a variety of different local efforts. So for example, I am one of the founding co-chairs of the Illinois Childhood Trauma Coalition's Committee on Refugee and Immigrant Children. And I also work with the mayor's office. They have an Office of New Americans, Chicago is With You task force, which is really tasked with operationalizing what it means to be a welcoming city or a sanctuary city. And we co-chair the mental health and wellness subcommittee of that group. So immigrant refugee mental health is a passion of mine, and as a result of that work, I have been involved on a national level with a work group that released a free resource guide on socioculturally attuned and linguistically responsive mental health care, which I'll be talking about today. But let me just back up for 1 second and say how pleased I was that Kendall asked me to be her discussant today. I feel like I've seen Kendall grow up. Before she was my research assistant, she started as a volunteer in my teen cognitive behavioral therapy group, and really was a wonderful help, and has been with me in one shape or another over the years. So it's really nice to see her advancing in her career, and I'm pleased to be here to talk today.
Thank you.
Okay, so if you can advance a slide for me, please. I'll start by just acknowledging that mental health assessment in an individual's non-primary language may impact the validity of diagnostic assessment and treatment planning decisions. And using an interpreter in mental health settings has been shown to be beneficial in that it improves communication, so there are fewer communication errors, there's better comprehension of diagnosis, and then there's also increased uptake in referrals provided and an increase in both client and provider satisfaction. Despite the critical role that interpreters have in the provision of child mental health services, they often don't receive specialized training in working with children, individuals, or families, especially those with no or limited English proficiency, nor do they receive training in how to partner with mental health clinicians. Clinicians also report not feeling equipped, trained, or culturally competent to work with international populations or with interpreters in therapy. So this is where I'm going to need a little tech support from you UIC folks. I'm wondering if we could see everybody's faces on the screen and get out of the slide share for a second, because I want to do a thumbs up voting system.
Okay.
And boy, I'm realizing I don't have the question choices in front of me, but what I'll do, or maybe Mike is he sharing it via chat?
You know what, everyone, if you're not able to turn on your video, you can also click the reactions button, and there's a way there that you can do a thumbs up as well. Okay, so the question I want to pose to the audience is choose the option that best describes your level of training or clinical work with interpreters. So if you can either give me a thumbs up or indicate in the chat box. I have participated in a lecture or a seminar on how to work effectively with interpreters. Can I see people's reactions there? How many people have attended a lecture or a seminar on how to work effectively? I'm seeing one thumbs up. Okay. The second option is I have had an informal conversation with a supervisor on how to work effectively with interpreters. I see 1, 2, 3. Okay. The next one is I've attended a multi-hour training with role play practice on how to work effectively with interpreters. 1. And the last one is I've never received any formal training to work with an interpreter. Okay, I'm seeing, okay, 1, 2, 3, 4, 5, 6. Yes, 7. Okay. So I am not surprised. Okay, we can go back to sharing the slides, Kendall. Thank you so much. But you guys have just demonstrated what we kind of knew
in our guts to be true that there has not been inclusion of this in most graduates' training curricula of how to work with interpreters effectively in our practice. And it ends up being kind of this anecdotal, casual conversation that you might have access to through certain supervisors, but it's not a standard part of our programs. So I want to go to the next slide and talk a little bit about the National Child Traumatic Stress Network. And they are, if you're not familiar with them, a network that provides free online training material. The resource I'm going to be talking about today, the Socioculturally Linguistically Responsive and Trauma-Informed Approach to Mental Health Interpretation, was developed as a dyadic training tool to increase the capacity and partnership of interpreters and mental health clinicians to improve quality of and access to mental health services for children, adolescents, and families with limited or no English proficiency. The aims are fourfold. First, they hope to prepare professional interpreters to work with children, adolescents, and families with limited English proficiency or who've experienced trauma. Secondly, to prepare qualified mental health clinicians to work with professional interpreters. Thirdly, to highlight the importance of and encourage developing a working partnership between interpreters and clinicians. And fourth, to offer recommendations of how to provide socioculturally, linguistically responsive and trauma-informed mental health interpretation to children, adolescents, and families with limited English proficiency who've experienced trauma. Next slide, please. So holding a socioculturally and linguistically responsive frame for children and families with limited English proficiency who've been impacted by trauma and are seeking mental health services essentially means understanding the importance of social, cultural, and language factors to their experience. For instance, when working with Latinx families, the child's and parents' level of acculturation can come into play in terms of how much they subscribe to traditional Latinx cultural values, for example, respeto or respect. It may be perceived as a sign of disrespect to inconvenience, to question, or make a request of a doctor. Asking questions and advocacy in mental health in any medical care really can be seen as a culturally foreign concept for those with limited education and high levels of respeto. Another traditional cultural value that may come into play in interpersonal reaction or relations in medical care is simpatia, the idea of the importance of warmth, kindness, and the emphasis on positive interactions, avoidance of conflict. And this may come into conflict with Western medicine's emphasis on professional, business-like, goal-oriented, and time-limited interactions with patients. Providing sociocultural and linguistically responsive interpretation in mental health settings recognizes that a one-size-fits-all approach doesn't work well. It should be avoided, and instead incorporate sociocultural and historical factors into the process. It requires both the interpreter and the mental health clinician to examine social cultural factors that influence their own thoughts, attitudes, and beliefs and behaviors, as well as to understand that the way a person behaves is influenced not only by the social and cultural groups to which they identify, but also social policies and practices of the systems in which he or she interacts and society at large. Linguistic responsiveness specifically refers to the recognition that language exists, that languages have different words for the same concepts, are pronounced in different ways between different countries. They may have different grammar structures. There is variation in dialects and meanings within language. If you just think about the heterogeneity of Spanish, for example, in all the Spanish-speaking countries. That goes for any language, really. In this resource, we also refer to understanding how language and linguistic varieties function and have purpose in the interpretation process, as well as appreciating others' languages and not assuming that speaking the same language equals perfect understanding. So sociocultural and linguistic responsiveness in mental health interpretation entails being open-minded, flexible, and able to identify sociocultural, historical, and linguistically relevant factors, such as awareness of multiple languages and dialects spoken by a population of a particular country and the issues, and awareness of ethnic religious group differences, and the potential for discomfort between a client and interpreter if they come from different groups. So a good example of this is when we think of Burmese populations and the ethnic group of Rohingya Burmese. It's not only a different language, it's very much a different culture, and there's quite a bit of discrimination. So you can imagine that if an interpreter came from a different Burmese-speaking ethnic group, it could create quite a high degree of discomfort. Next slide, please. We also discussed the SAMHSA's trauma-informed care framework, and that's highlighted throughout the guide to help interpreters understand populations impacted by trauma. So the framework offers a vision of trauma-informed organizations that adhere to the 4 R's. We want to realize the widespread impact of trauma and pathways to recovery. We want to recognize trauma signs and symptoms. We want to respond by integrating knowledge about trauma into all facets of the system. And we want to resist re-traumatization of trauma-impacted individuals by decreasing the occurrence of unnecessary triggers, which can be trauma or loss reminders, and implementing trauma-informed policies, procedures, and practices. Next slide, please. In addition, the guide encourages interpreters and mental health providers to be aware of generational and contextual factors that may impact populations with limited English proficiency. Hopefully, this pyramid of adverse childhood experiences is familiar to you. We know that childhood experiences of abuse, neglect, parental substance abuse, mental illness, and incarceration can impact adult mental and physical health outcomes in the long term. We know that ACEs are really common, that they often occur together, and that they hold up across diverse populations. What this pyramid adds is a contextual lens and chronic stressors. Many marginalized and minority populations experience what we call historical trauma, which has been defined as cumulative and psychological wounding over the lifespan and across nations emanating from massive group trauma experience. And here I want to emphasize the intergenerational transmission of the effects of trauma. So here we're talking about events that target a whole community and not just an individual. Even those who have not directly experienced the trauma can feel the effects generations later in the form of unresolved trauma and loss. And this experience has been described amongst Native Americans, African Americans, Jews, and other ethnic and religious minorities. It includes planned government actions such as forced relocations, slavery, federal takeover of sacred spaces, prohibitions against ceremonial practices, genocide, and unethical science experiments. So as a result, minorities have healthy governmental and institutional distrust, which often serves as a barrier to help seeking. In terms of the response to historical trauma, we often see unresolved grief and anger, in turn contributing to physical and behavioral health disorders and substance abuse. Historical trauma shapes the way that people also respond to current traumatic stressors. So if you're undergoing daily reminders of racial discrimination and microaggressions, that can really exacerbate your response to current traumatic stress. If we think about the legacy of slavery that has been carried forward in many areas of American society, including racial injustices that persist, such as mass incarceration and lethal violence used by law enforcement toward African American males. So historical trauma is one type of chronic stress that can present in a variety of different ways. For example, communities are affected by chronic stressors such as microaggressions, those covert interpersonal and environmental events involving discrimination and racism, and daily hassles that are targeted at individuals from diverse racial ethnic groups. Bullying based on minority status, exposure to mistreatment by police of family and community members, fear of deportation and separation from parents. And these experiences really serve as the backdrop for all other types of adverse experiences an individual might be exposed to. Next slide, please. So I do want to say that not every person with limited English proficiency is an immigrant or a refugee, but many of them are. So let's take a quick look at some of the contextual factors that may be playing into these populations' response to treatment providers and mental health services, because many of these factors may play into why families may refuse interpretation services, which is one of Kendall's questions today. So looking at these headlines, you can get a feel for how people in marginalized groups may be experiencing increased stress in the last 2 years. Stereotyping certainly has been reinforced, whereas before it was less socially acceptable to use hate speech or express prejudice. rhetoric has fostered a sense that these sentiments are sanctioned or more acceptable. We've certainly seen white supremacists emboldened by political rhetoric. And the Southern Poverty Law Center has noted an increase in vandalism, threats, and intimidation. On a more individual level, we know that there's evidence that students have interpreted political rhetoric as giving them permission to bully other students of color and of minority statuses. Youth who are victimized by bullies are demonstrated to show higher risk for severe mental health concerns. So ethnically diverse students, regardless of where they're born, are often being told to go back to where they came from. Refugee students are getting called terrorists or bullied for the way that they dress, speak, and act. Next slide, please. And I also want to give a quick review of how recent policies may be impacting families' decisions to make requests of their healthcare providers versus just trying to fly under the radar. In August 2019, it was announced a final rule that changes the public charge policy used to determine whether an individual applying for admission or adjustment is inadmissible to the US. Under long-standing policy, the federal government can deny an individual entry into the US or adjustment to legal permanent resident status or a green card if they're determined likely to become a public charge or dependent on public benefits. Under the rule, officials will newly consider use of certain previously excluded programs, including non-emergency Medicaid for non-pregnant adults, SNAP, or the Supplemental Nutritional Assistance Program, and several housing programs in public charge determinations. The change creates new barriers to getting a green card or immigrating to the US and has already created confusion and fear, causing disenrollment in Medicaid and other programs among immigrants that are actually entitled to be enrolled in those programs. Decreased participation in these programs can contribute to more uninsured individuals and negatively affect the health and financial stability of families and the growth of healthy development of their children. The last couple of years have evidenced a sharp increase in immigration enforcement actions, including apprehensions at the border, detainment, and deportation. This has resulted in an increase in child-parent separations and often the loss of major breadwinners for many families, leading to economic hardship and housing instability, food insecurity. We also have seen a change to the asylum rule, which renders asylum seekers who pass through another country first and have not sought asylum in that country, it renders them ineligible for asylum at the US border. This effectively makes it virtually impossible for Central and South Americans to qualify for asylum. And finally, in January 2020, the head of ICE told reporters that if the Supreme Court ends DACA, a decision that's expected any day now, the agency would be able to go after DACA recipients who had previous deportation orders. So this raises a lot of concerns for confidentiality, since promises were made to DACA recipients about how the government would not use their information for deportation purposes. So in response to Kendall's question about how legal status affects help seeking and self-advocacy, we have to remember that over 9 million people live in mixed status families and have at least one undocumented adult and at least one US born child. That's a lot of folks. So more and more we're seeing that people living in such families really are doing everything possible on a daily basis to fly under the radar and not make waves. And that plays out in their help-seeking behaviors. Next slide, please. So I think, what can we do when a family is refusing an interpreter? That's why we're here today. So obviously, we want to try to make a case and explain the benefits of a professionally trained interpreter and the rules around confidentiality to reassure them. We want to talk about the benefits of getting a high-quality assessment, a more accurate diagnosis. We want to talk about this is a way for your family to be actively engaged in treatment planning, and it helps everybody understand better and agree on what the treatment plan should be. So for many refugees and immigrants and others with no or limited English proficiency, their country of origin may not have patient protection laws, and the concept of HIPAA or privacy of medical records is totally new to them. For these reasons, many refugee and immigrant and other clients with no English proficiency have fears that engaging in psychiatric treatment, receiving a diagnosis, being psychiatrically hospitalized, or taking psychotropic medicine would jeopardize their immigration proceedings or asylum applications. None of this is true, but many have those fears because that's the way things work in their countries of origin. Others fear that diagnoses might appear on permanent records and would be accessible to college admissions offices or future employers. Therefore, it's crucial for interpreters and clinicians to clarify the HIPAA rules around confidentiality and to explain that interpreters and medical providers are all bound by law to keep client information private. Interpreters can also explain that a client's legal status will not prevent them from receiving care, nor will it be documented in the medical record. And that reminds me, I know Kendall mentioned earlier that she hadn't inquired about the patient's legal status. And that's not something I would necessarily encourage people to be asking their clients on a regular basis. What we want to focus on is making it a safe space for them to divulge that, normalizing that many of the families with whom we work are experiencing hardships or adversity, and we are very open to working with them on, you know, relieving any stress that they may have. It might be legal, it might be immigration related, etc. So you kind of make it okay to talk about it and clarify that none of that will be documented in the medical record. Patients, at the end of the day, though, can refuse interpretation services. And as Kendall mentioned, it has to be documented. But if the patient chooses to say, I'd rather have my family member translate, kind of an ad hoc interpreter, the organization still can choose to have a professional interpreter present to oversee the communication and to ensure that the provider is understanding all that is being said. So, for example, I understand that you don't want an interpreter, that you want your family member to translate for you, but I want an interpreter so that I make sure I'm understanding everything correctly. According to Title VI of the Civil Rights Act, institutions receiving federal funding are required to provide interpretation. So that's something also that we can highlight with patients. Next slide. Okay. Kendall, can I actually ask you to unmute yourself? And I would like you to actually read, this is a sample script of when a family suggests using an adult family member to interpret for them. This is a way that you could maybe discuss it with them and encourage them to accept the professional interpreter services.
Okay. Am I muted right now?
No, I can hear you.
Okay. Okay. So you'd like me to practice doing this?
Sure, if you could just read it out and see how that feels. Mm-hmm.
So it is your right to refuse the services provided. Nevertheless, at Lurie Children's, we offer the services of trained interpreters so that your uncle, sister, or friend can fully support you in his or her role. We are here to help you. Often family members find that their emotional attachment can cloud their ability to remain neutral and cause them to make errors. You are welcome to have your family member interpret for you if you feel more comfortable, but in order to ensure that everything that you and I say is being accurately interpreted, I would like to have our interpreter present for our meeting. Please know that professionally trained interpreters have to abide by the same rules of confidentiality that medical professionals do.
Okay, so that's a very scripted way. It's just an example. I don't expect people to memorize that, but that is a way that we suggested in the guide of how you could explain to families that this is a service that they can access and that you feel strongly enough about having a professional there that it would be beneficial to both, but they can continue to use their family member if they feel better about that as an option. Okay, and let's take the next slide and do the same thing. So again, according to Title VI, children can interpret in cases of emergency where there are no other resources available, like in the cases of rarely used languages, when an adult is critically ill, if they're in the emergency room and there are really no interpreters available in person or by phone. But those are really extenuating circumstances. So we really do want to help families understand why it's not appropriate to have children interpret in medical settings. So why don't we try reading that one, Kendall?
Yeah. So I understand that you would prefer that your child interprets for you. However, we don't expect children to have vocabulary or maturity to accurately interpret medical terminology. We also may discuss topics during the evaluation and therapy that are mature in nature, things that we don't usually discuss with children. That might cause the child unnecessary distress. We provide interpretation services at no cost so our patients and families can focus on their concerns and well-being. For these reasons, at Lurie Children's, our policy states we cannot use minors to interpret. We offer professionally trained interpreters who abide by the same rules of confidentiality that medical professionals do.
Okay, thank you. Thank you for playing along. So I just wanted to give you some ideas of how you could discuss these issues with families and how we can make it safe, and really make sure that we're considering and maybe having on our radar that families may be reluctant to ask for or accept services simply because they are concerned about whether they can trust you and whether this is something that is going to cause them to be detected and endanger themselves or someone in their family in terms of deportations. Okay, so last slide is just a thank you slide, and I think we have enough time for some questions at the end. Is that right?
Yeah. Yeah, we're running a little late in time, but I do see that we do have some questions below in the chat room. And if anyone else has questions, feel free to use one of the reactions to notify us or to place them in the chat box. So first, what I'm seeing is that, one of our participants, Kevin, said that in India, many people speak English, but many of them are not what we would consider to be fluent, which I think was really good to know. However, they sometimes feel insulted if an interpreter is called. I or the provider, and Kevin is an interpreter, as he states later, often have to explain to them that they may speak English, but we have to ensure they understand all the nuances of the appointment, which I think is really great to know. And if anyone else has any questions to put in there, feel free to. I think it was a really great addition, though, that you put in those scripts of what we could say, because that was, I think for me, as I said in my presentation, I did feel a little bit uncomfortable because I didn't know how best to navigate speaking to mom about the benefits of having an interpreter in a way that was also respectful of her rights. And I also, and then also not wanting to insult her as well.
Pros and cons, right? Is it more important to make sure that you haven't offended, or is it more important that they have all of the information needed to make a good and informed decision? Obviously, we want both, right? But I think that it is every situation is different, and you may make a different decision in every situation. But I think as a general rule of thumb, we definitely want to encourage and educate families about interpreter services, why how they are superior to using family members or just kind of toughing through it in English. So it's delicate, I understand, but at the same time, I think there are ways to make it okay and make it safe.
Yeah. And also, we were able to unmute people, so if you want to, you can ask a question with your voice instead of typing it as well.
Sure. I had two thoughts about it. I wanted to clarify that I understood correctly that Celeste and her father can't communicate because she doesn't speak enough Spanish. And he doesn't.
So that was a pretty interesting dynamic. I myself wasn't able to view it. And to be quite honest, this is actually not something I have never heard of before. I have friends even where one of their parents speaks Spanish only, and the child then knows a few words in Spanish, but is primarily English speaking. And outside of the limited interactions they have with maybe their mom or dad, they're not able to, I would say, speak fluent Spanish. So with Celeste's case, I didn't actually visually see it, but in speaking with dad, he really didn't speak enough English. I wasn't notified in advance that he didn't speak English, so I tried calling him in English, and I realized we needed an interpreter. So with Celeste, she told me she just doesn't really talk to dad, and that usually everything just goes between mom and for that family.
At least in my experience, I know many adolescents who prefer not to communicate very much with either or both of their parents, but to literally not be able to, I can understand not being able to convey sophisticated concepts, but more basic concepts. It just seems like a metaphor for her problems in general. right? That they can't talk to each other.
Yeah, and it's completely possible that they are able to have basic communication, and that I just wasn't aware of that since I only really got to work with them for 2 days in total. So it seemed like oh yeah.
Oh, I was just going to jump in and say it's not uncommon that we see this. We've had to create safety plans, for example, bilingually, so that everybody knows exactly what it says on there. So we're all clear on it. But you're right. I think there is a degree of how much can the parent really be emotionally available to their adolescent if they don't speak enough of a similar language. I also want to point out that father was never able to come in during the 5-day stay that his daughter was hospitalized. So I think some providers may interpret that as a disengaged parent, or he doesn't care. But I think if we're talking about a family of undocumented status, another way to look at it is that if he had not gone to work, he would not have a job. He doesn't have the luxury of taking a sick day. He does not have any rights or privileges in his jobs to be able to attend to his sick daughter. So, in terms of Maslow's hierarchy of needs, the need to provide for his family and put food on the table supersedes that of emotional support. Maybe not just that week, but generally, right?
Yeah, one of the other things that made me think about is, if perhaps Celeste was separated from either or both parents for part of her childhood, which is the reason that she doesn't speak more Spanish, or something else going on there. And the other thing I wondered is actually when I saw the beginning slides that it's the Pritzker psychiatric unit, if families might associate that with the governor and think that the hand of the state is in there, and that might be anxiety provoking for them.
Absolutely, very good point.
Yeah.
Thankfully, we have a governor who's relatively friendly towards immigrants.
Right. Thanks.
Yeah, I was just going to say, can you hear me? I think this is Joy.
Yes.
That was interesting. Well, all of it's been very fascinating, but I think that the issue, Rebecca, that you raised about his not being able to go to work, there are many times, many more people who can't take time off from work, and they may be citizens. So, I mean, there are a lot of issues here, but when the interpretation of a father not being able to be there, or a mother, is very disturbing to think that would be the first thing that someone might think of, because and as I know, I know, and I've known enough providers in my life, and I've talked a little bit with Kendall about some of these issues, and that's why if you don't have a broader, putting my public health instructor, live, breathe public health person hat on, if you don't see this patient in the context, it's just another example, like many reasons why a parent couldn't come.
Right.
And so I'm preaching to the choir, but I just thought I would make that point.
And it's good to have those reminders, because I think, especially when you're working and you're in these settings, it's very easy to forget and to also blame parents a little bit, like, why aren't they answering the phone? Don't they realize this thing is happening? And just because we kind of get so absorbed with our own lives, which I think is one of the nice things about me only having that one patient at a time during my internship, because then that put me in a position to better advocate for the patients, but also to not fall susceptible to that, to be able to continue to catch myself and self-analyze what's the reason for what I'm doing. Okay, so,
hello.
Yeah.
Really quick, hi. I just wanted to say I did really like this presentation, both aspects of it. I'm also a joint degree student about to graduate, so it's exciting, but I'm also Hispanic, and my grandma came here from Mexico, and even like as her granddaughter, seeing how she interacts with the healthcare system, even knowing what I know, it's still, there's an aspect to it that is really frustrating, right? Because just like we mentioned, there's always like, oh yes, I don't want to ask any questions to a doctor. I'll just take whatever they say as Bible, and then after that, I'll just kind of figure it out on my own. And I think that, like, even from my own perspective, like totally understanding where it comes from, it is frustrating. And so it's really reassuring and really great to see that, that's recognized and that's something that you're actively working toward to discuss. But I'm just wondering where I could access maybe a resource guide or something else, just so I could better familiarize myself like with the topic and other aspects to better educate myself.
Well, the resource guide that I mentioned, Kendall, if you want to put my slide up again, that's available on the NCTSN website, as are many, many other resources. So that would be a good place to start. If you're doing work specifically in refugee mental health, they have a whole refugee mental health toolkit and assessment instruments and things to be looking at. So if you haven't, or if you're not familiar with that website, I would highly recommend it. If there are other resources, like specific resources that you're interested in, I'm happy to try and connect you with others.
And I saw some questions. This is all being recorded as well, in case anyone would like to access it later or share it. Okay. So if we don't have any more questions, I'd like to thank you for everyone actually for coming to join us today and taking the time out of your day to make this work. And also, of course, many thanks to Dr. Ford-Pa for joining me on this.
You're welcome. It was a pleasure.
Thank you.
Yeah, thank you all so much for coming, for participating. This is a great ending for this great experience that Kendall had, and we've had having you here. And thank you, Dr. Ford-Pa, for contributing. It was very, very interesting and very useful to us. So I guess that's it. So thanks again, Kendall. You did a wonderful job. Make us proud. And I'm glad to see your peers here at the in the public health school and the social work school and at Lurie's. So thank you all, and stay safe.
All right, you too.
Thank you, everyone.
Thank
Bye.
you.